I'm Jim Beckmann, an interventional cardiologist at the Cardiovascular Institute of North Colorado Medical Center. I was interested in when could a practitioner, once they start learning transradial technique, can they incorporate it into treating acute ST elevation MI? One of the things we want to make sure we don't do is delay revascularization, because we know that opening the infarct-related artery is beneficial. Any delay in a new technique may reduce the benefit that they would get from early revascularization. So I chose to look at, does radial access slow door-to-balloon time? Door-to-balloon time is really a very aerial view at the process. And it includes multiple processes, not just the radial technique, but actually how quickly can you get them to the cath lab. Then the important part for the radial access is how quickly can you get the patient ready and prepped for radial access, and then how adept, how comfortable are you in your technique in accessing the radial artery and then passing the catheters through the brachial, through the subclavian innominate artery to the ascending aorta, cannulating the arteries, and then using the devices. So I chose to look at that to make sure that I wasn't delaying door-to-balloon time, or more specific, cath lab time. We looked at all comers, except I did exclude, since it was my first patients for primary PCI, I excluded those that were obviously shocky, those that required vasopressors or mechanical support because of blood pressure, and I thought maybe I was going to increase the incidence of vasospasm, which was going to reduce my ability to use radial access, and those that were going to require temporary pacing, because then I needed very emergently venous access also. But then looking at these patients, what was discovered was that there was actually minimal delay in using the transradial access as opposed to transfemoral access. The agility with the catheters, the support from the guides, getting the first device across, minimal delay, mean of approximately 2 to 3 minutes. Take-home messages: I think a practitioner who is trying to incorporate radial access and really gain the benefit, and I think now several studies have shown that primary PCI for acute ST elevation MI is beneficial to the patients if the transradial access is used. Obviously, less bleeding, access site bleeding, is uncommon radial versus femoral. The practitioner, once they are comfortable with the catheters, with the access, and I chose 100 for my own comfort level, if they track their numbers, probably can incorporate transradial access for treating primary PCI. It offers several things that we sometimes don't even think about, though, and that is for the patient, their comfort, particularly their safety, which they may not be aware of, but one that we're doing, because I can reduce bleeding at least by 1/3 by taking away the access site bleeding. So I think an operator, after doing at least 100 cases electively, could start looking at their use of the transradial access in primary PCI for acute ST elevation MI.